Welcome to the deep dive. Today we're tackling a big one, personality disorders. We're basically giving you a study shortcut, pulling the absolute essentials from a major psychiatric nursing textbook chapter.
That's right. Our goal here is pretty straightforward. We want to lay out the 10 main personality disorders for you, what they look like clinically, some of the biology and psychology behind them, which can be quite surprising, and critically, what you actually do as a nurse, the effective interventions.
Okay, let's start right at the beginning. The source text mentions the Latin root persona, meaning mask. So what is personality, fundamentally?
Well, it's defined as that relatively permanent pattern of thoughts, feelings, and behaviors. It really defines how a person experiences life and relates to others. It's, what makes you uniquely you.
Got it. And then when does having a personality cross over into, well, being a disorder? When is it unhealthy?
It hits that point when those patterns become consistently maladaptive, when they get complicated or cause ongoing distress, what we call dysphoric. Basically, when someone's inherent traits start causing persistent problems in their relationships or just general emotional pain.
Okay.
And actually, here's something interesting the text points out. You know that old saying about personality being set like plaster by age 30?
Yeah, I've heard that.
Well, current thinking challenges that. It seems personality can keep changing throughout life. It definitely slows down the rate of change, but it doesn't just stop.
That's actually quite hopeful.
Yeah.
But the book highlights a major challenge right off the bat for clinicians, doesn't it? That people with these disorders often don't see the problem in themselves.
Exactly. They tend to externalize it. They genuinely believe the issue is, out there with everyone else, or they're just totally unaware that their behavior might seem unusual or even destructive to others.
That lack of insight must be huge.
It is, and it brings up a really critical point about diagnosis. The cultural context. You have to be so careful not to overdiagnose, especially when working with people from different cultural backgrounds. What seems eccentric in one culture might be perfectly normal in another.
Right. Context is everything.
Definitely. Clinicians really need to consider ethnic, cultural, and social backgrounds. Hashtag the 3 clusters of personality disorders. Okay, so to help organize all this complexity, the American Psychiatric Association, the APA, groups the 10 personality disorders into 3 main clusters. It's based on shared behavioral patterns.
Okay, lay out the clusters for us. What's the map?
Sure. So cluster A is known as the odd or eccentric group. That includes paranoid, schizoid, and schizotypal personality disorders.
Odd or eccentric, okay.
Then you have cluster B. This is the one that often gets the most attention, the dramatic, emotional, or erratic cluster. Here you find borderline, narcissistic, histrionic, and antisocial PDs.
Right, the sort of high-intensity, high-volatility group.
That's a good way to put it. And finally, there's cluster C, the anxious or fearful cluster. This includes avoidant, dependent, and obsessive-compulsive personality disorders. Hashtag exploring the eccentric and the anxious. Cluster A and C.
All right, let's do a quick run-through of clusters A and C, the eccentric and the anxious ones. Starting with paranoid PD. What are the hallmarks there? Pervasive distrust, suspicion.
Exactly, and hypervigilance. They're always on guard. The textbook notes their primary defense mechanism is projection, attributing their own unacceptable thoughts or feelings onto others.
So, with that constant mistrust, what's the key nursing approach? You probably can't just be warm and fuzzy.
No, warmth isn't the main thing. It's about reliability, absolute predictability. You have to stick to schedules like glue, keep every promise. That consistency directly challenges their core belief that people are out to get them. The approach should be neutral, kindly, professional, and importantly, you need to set clear limits immediately as any threatening behavior pops up.
Okay. Moving on to schizoid PD. The book describes this as lifelong social withdrawal, a really restricted emotional range, detachment, maybe even feelings of depersonalization.
Yes, they often seem quite aloof and are generally comfortable being alone. So the nursing approach has to respect that. Trying to be overly nice or pushing them into social situations can actually feel intrusive and counterproductive.
So you don't push socialization.
Not initially. It's more about helping them manage any anxiety they might experience. Down the line, group therapy might be useful, but usually just as a place to practice basic social interactions, not really for deep emotional connection or sharing.
Makes sense. And then the third one in cluster A, Schizotypal PD, described as strikingly strange, maybe magical thinking, odd speech, paranoia. How is this different from something like schizophrenia?
That's a crucial distinction. The key difference is insight, or at least the potential for it. Unlike individuals with schizophrenia, people with schizotypal PD can sometimes be made aware, even if briefly, that their beliefs are odd or their suspicions might be unfounded.
Oh,
That being said, the textbook does note they share some brain abnormalities with schizophrenia patients, like reduced cortical volume in certain areas. Nursing-wise, you respect their need for isolation, but you always assess for suicidal thoughts, as this is sometimes what brings them into treatment.
right. Okay, let's shift gears to cluster C, the anxious or fearful types. First up is avoidant PD. These individuals desperately want connection, right? But they're held back by this intense fear of rejection and feeling inadequate.
Exactly. They're extremely sensitive, so the nursing strategy here needs to be really friendly, accepting, and reassuring. Build that trust slowly. Assertiveness training can be very helpful for them.
But you shouldn't push them too hard.
Definitely not into social situations they're not ready for. That
Yeah.
can seriously backfire and just reinforce their feelings of worthlessness. Gentle encouragement is key.
Okay. Then there's dependent PD.
Mm.
This sounds like submissive behavior, clinging, needing to be taken care of, terrified of separation.
Yes, that's the core of it. Interestingly, the therapeutic relationship itself becomes a key tool here. It's a safe space where the nurse can help the patient practice being more assertive, making small decisions independently.
I imagine that can be challenging for staff, too.
Oh, absolutely. The textbook specifically mentions the risk of countertransference. Because these patients can become very demanding, especially in crisis, staff might develop strong negative feelings, which obviously complicates care. Supervision is really important here.
Good point. And the last one in cluster C, Obsessive-Compulsive Personality Disorder, OCPD. Rigidity, stubbornness, perfectionism. No, wait, this is where we need that critical distinction.
Yeah.
How is OCPD different from OCD, Obsessive-Compulsive Disorder?
This is a really important one to get straight. It boils down to whether the patterns are egosyntonic or ego-dystonic. Meaning, people with OCPD are generally comfortable with their rigid rules and perfectionism. They see their way as the right way. That's egosyntonic. They don't usually see a problem with it. Whereas people with OCD typically recognize that their obsessive thoughts and compulsive behaviors are irrational and distressing. That's ego-dystonic. They wish they could stop. That insight is the key difference.
So OCPD folks think their systems are correct.
Precisely. For nursing care, you need to provide structure, which they often appreciate, but also allow them extra time for their routines. And critically, you have to actively guard against getting into power struggles over the rules.
All right, let's turn the spotlight onto cluster B now, the dramatic, emotional, erratic group. Starting with histrionic PD. The textbook paints a picture of drama queens, excitable, colorful, maybe needing to be the center of attention.
That's a fair summary. They're often very expressive, maybe even theatrical, seeking attention and approval constantly. Relationships can be tough because their focus tends to remain very self-centered, despite appearing outgoing.
So what's the nursing angle? How do you manage that intensity?
Professionalism is key. Keep communication clear and focused. It's important to recognize that sometimes seductive or overly dramatic behavior is actually a sign of distress, not genuine intimacy seeking. A really useful intervention mentioned is encouraging them to use more concrete, descriptive language instead of vague, impressionistic terms. Helping them say specifically what they feel, rather than just, "Oh, it was terrible," can actually help them clarify their own emotions.
Interesting. Okay, moving to narcissistic PD. This sounds like entitlement, big sense of self-importance, lack of empathy, maybe antagonism.
Yes, those are the classic features. Arrogance, needing admiration, exploiting others, feeling they deserve special treatment.
But the textbook points out something surprising underneath all that.
It does. It suggests that beneath the surface grandiosity, there's often actually quite fragile self-esteem. Intense shame, maybe, and a deep fear of abandonment. The arrogance is really a defense mechanism.
That makes the remain neutral advice seem incredibly difficult. If someone's acting entitled and demanding special treatment, how do you stay neutral without getting into a fight?
It is tough. The key insight is that directly challenging their grandiose statements often just triggers that underlying shame and makes them dig in harder. So neutrality means not getting drawn into arguments, not validating the grandiosity, but also not attacking it.
So what do?
You focus on role modeling empathy yourself. You acknowledge their feelings without necessarily agreeing with their demands. The long-term goal is to gently help them build a more realistic and resilient sense of self, rather than relying on that fragile, inflated one.
The text also briefly mentioned a cultural aspect.
Yeah, just a note that how narcissistic traits, especially in leadership, are viewed might differ culturally. For example, maybe more accepted or even valued in some highly hierarchical structures, like perhaps in certain business contexts in China, compared to the more individualistic focus often seen in the US. Just something to be aware of.
Okay, let's shift into our first deep dive. Borderline Personality Disorder, BPD. The source material calls this the best known and most dramatic of the PDs, marked by real instability, impulsivity, and often severe functional impairment.
It really is characterized by volatility. There are a few core features. First, emotional dysregulation and lability. This means their moods are poorly controlled. They swing rapidly from one extreme to another, intense anger, depression, anxiety, and often these shifts feel way out of proportion to whatever triggered them.
Okay, intense mood swings. What else?
Second, significant impulsivity, acting quickly without thinking through the consequences. This can manifest in things like reckless spending, substance abuse, unsafe sex, binge eating, or even self-harming behaviors.
And that leads to maybe the most well-known feature, that defense mechanism, splitting. Can you break that down?
Sure, splitting is essentially an inability to see the shades of gray in people, including themselves. They can't integrate the positive and negative qualities of a person into a cohesive whole. So people are seen in extremes. Like you, the nurse, might initially be idealized. You're the perfect, understanding caregiver, the angel of mercy. But then, the moment you disappoint them, even in a small way, maybe you're late with medication or have to enforce a rule, you instantly become devalued. You're suddenly all bad, the worst nurse ever.
Wow, that must cause chaos on a team.
Oh, it absolutely can. This idealization devaluation cycle often leads to conflict among staff members as different people get put in the good or bad category by the patient.
Let's talk about where this comes from. The book mentions Margaret Mahler's psychological theory.
Yes, Mahler's developmental theory suggests a disruption during a key phase in early childhood called separation-individuation, specifically the rapprochement stage, which is around 18 to 24 months.
What happens then?
Well, this is when a toddler is exploring independence but still needs to come back to the caregiver for reassurance. If the caregiver is inconsistent, maybe punishing the child's attempts at independence, or is unavailable, the theory suggests the child develops this intense, deep-seated fear of abandonment. And that fear gets carried into adulthood, fueling many of the BPD behaviors like frantic efforts to avoid being left alone.
That really connects the dots with the fear of abandonment. What about the biology? Is there evidence there too?
Definitely. BPD is considered highly heritable. There's a strong genetic component. Neurobiologically, research points pretty clearly to dysfunction in the serotonin system, which is linked to impulsivity and aggression.
And brain imaging.
Neuroimaging studies often show this interesting imbalance. The amygdala, which is like the brain's emotional alarm center, seems to be hyperactive. It fires off really easily and intensely. But at the same time, the prefrontal cortex, the part responsible for planning, judgment, and emotional control, appears to be less active or effective. So you get strong emotions firing off without enough regulatory braking.
Okay, so intense emotions, impulsivity, fear of abandonment, splitting. Given all that volatility, the textbook flags risk for self-mutilation as a major nursing priority. How do nurses manage that? Especially the need to stay neutral when dealing with what can feel like constant crises or self-injury.
It's incredibly challenging. The absolute foundation is providing clear, consistent boundaries and limits. That structure is vital.
And for the self-injurious behaviors themselves. If they're superficial, done more for tension relief.
The recommended approach is to remain neutral and matter-of-fact while attending to the physical wound. Then, and this is a key intervention, the patient is typically instructed to write down the sequence of events, what led up to the self-harm, what happened during, and what the consequences were, before discussing it extensively with staff.
Why the writing exercise?
It's a cognitive technique. It encourages them to pause, reflect, and think through the situation independently, rather than immediately relying on staff to process it or acting purely on impulse. It promotes self-awareness and problem-solving skills.
Makes sense. And what about formal treatment approaches?
The gold standard, evidence-based therapy, especially for individuals with BPD who are chronically suicidal, is Dialectical Behavior Therapy, or DBT.
What does DBT involve?
It's really clever. It combines cognitive and behavioral techniques, challenging thoughts, learning new behaviors, but integrates them with core concepts from mindfulness practice, things like distress tolerance, emotion regulation, and interpersonal effectiveness skills. CBT, cognitive behavioral therapy, and schema-focused therapy are also used.
Okay, let's move to our final deep dive. Antisocial Personality Disorder, ASPD. Often called sociopathy in popular culture, though that's not the clinical term. The textbook describes it as a pervasive pattern of disregard for and violation of the rights of others. It often emerges in adolescence, peaks in the mid-20s, and maybe sometimes lessens around age 40.
That's the general trajectory, yes. The absolute core pathology here is this profound lack of interpersonal connection and concern for others. Key traits include callousness, a real lack of empathy. They often show no remorse or guilt for their actions, unless perhaps they're facing punishment.
So no genuine remorse. What else?
You also see significant antagonistic behaviors. They tend to be deceitful, manipulative for personal gain, maybe hostile or irritable. They can exploit others quite callously. Interestingly, they can sometimes be superficially charming or use flattery very effectively to get what they want.
Okay, so charming but manipulative, lacking empathy. If they're often deceitful, what's the biggest hurdle for staff when trying to assess them or plan interventions?
Well, first off, they rarely seek treatment on their own. It's often court-ordered or comes up when they're being treated for something else, like substance abuse. During assessment, they're frequently defensive, maybe minimize their problems, or are just plain untruthful.
So assessment is tricky.
Very. But perhaps the bigger challenge the textbook emphasizes is the internal one for the nursing staff. These patients can really push buttons. Staff need intense self-awareness and access to clinical supervision. Why? Because patients with ASPD can evoke really strong and sometimes problematic reactions. Staff might feel overly sympathetic if the patient uses charm effectively, or conversely, they might feel intimidated, angry, or personally threatened by aggressive or manipulative behavior. Maintaining objectivity is crucial, but hard.
Given that risk and the disregard for others, I'm guessing the priority nursing diagnoses reflect safety concerns.
Absolutely. Risk for other-directed violence and impaired impulse control are often top priorities. The interventions really have to focus on setting clear, firm, realistic limits and boundaries. And importantly, consistent consequences for breaking rules like loss of privileges and rewards for adhering to them.
And dealing with the manipulation.
You have to address it directly, calmly, and matter-of-factly. Pointing out manipulative behaviors like flattery or intimidation, setting limits on them, and explaining why they're not acceptable within the therapeutic relationship. If anger or aggression starts to escalate, therapeutic communication focuses on trying to understand the feeling behind the anger without excusing the behavior and providing safe physical outlets like walking or exercise to help manage that impulsive energy. #tag outro. So just to wrap things up quickly, the common thread through all personality disorders is this pattern of inflexibility and difficulties in relationships. They really stem from a complex interplay of biological factors. We talked about neurotransmitters like serotonin and brain structures like the amygdala and prefrontal cortex and psychosocial factors like early developmental disruptions.
Uh-huh.
And for healthcare staff working with these individuals, the universal need, really highlighted in the text, is for ongoing clinical supervision. It's essential for managing those intense emotional reactions we discuss and making sure the team approach stays objective and consistent.
And despite how ingrained these patterns seem, the source material does offer a small note of hope, doesn't it? It suggests that while personality is relatively stable, some motivated patients can achieve real, though often small and incremental, changes in their behavior over time. It takes consistent specialized treatment, but change is possible.
It is. Which kind of leads us to a final, perhaps provocative question for you, our listeners, to think about. Considering what we now know or are learning about the clear neurobiological underpinnings of some of these disorders, like the hyperactive amygdala in BPD or the serotonin issues linked to ASPD, how might this deeper physiological understanding start to change how we as a society think about things like legal accountability, culpability, and also the kind of long-term support individuals with these really entrenched patterns might need?
That's a huge question, definitely one that bridges clinical understanding with broader societal and ethical considerations. Food for thought. Thank you so much for joining us for this deep dive into personality disorders based on Varcarolis' foundational text. We hope the shortcut was helpful. We'll see you next time.